Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is sponsored by the award-winning quarterly journal, AACN's Advanced Critical Care, with information available at www.aacn.org/advancedcc. Now, here are your hosts, AACN's Chief Clinical Officer, Vicki Good, and Clinical Practice Specialist, Andrea Schmitt.
Hi, this is Andrea Schmitt, and welcome to the Voices in Nursing podcast. I'm here with my co-host, Vicki Good, today.
Hello, everyone.
Vicki and I are really excited to chat with Kelly Kester from Duke University Health Systems on all important topics of staffing and healthy work environments. Before we start, though, tell us a little bit about yourself, Kelly.
Sure. Well, first, thanks for having me today. Like you said, my name is Kelly Kester. I work for Duke University Hospital in Durham, North Carolina, and I am currently a nursing director for Heart Services. I've been with Heart Services for about 15 or 16 years, believe it or not, and I just love the work that I do in leadership, particularly as it supports healthy work environments and specifically appropriate staffing. That's kind of where I found my niche. I do a lot of quality improvement in that space. Education-wise, I got my master's degree at East Carolina University in North Carolina and a doctorate at Duke University School of Nursing. And I'll just say graduate school changed my life and the trajectory for my nursing leadership pathway. So I'm excited to kind of talk to you about how that's all tied together today.
That is incredible. And I'm super excited because, Kelly, I've read a lot of your work and you've done some amazing things regarding nursing leadership. And that is truly a passion of mine. And I remember the day that I was tapped on the shoulder to go into leadership. And I want to focus on when you were tapped on the shoulder. And one of your first things that you wanted to focus on was reducing staffing turnover. But as you quickly learned, it's a little bit broader than just staffing turnover. And that's when you joined the journey of providing healthy work environments for your team. And that's when you discovered AACN's Healthy Work Environment Standards, which I've been a fan of since they were published in 2005. But how did you start that journey with HWE?
Such a good question. I was tapped on the shoulder, just like you were, about 11 years ago. And it was one of those things of, I'm going to need you to do something for us. And there was specifically a clinical nurse manager position of the cardiothoracic ICU in which I was a bedside nurse. Specifically, I was a night shift nurse who was really just getting involved in orientation, unit-based education, a preceptor, a charge nurse, things of that nature. And I saw this as a really great opportunity, not realizing that it was going to lead to a whole career in leadership. To be honest, I love the bedside and fully expected to go right back once this tap on the shoulder was, completed. But it was an interesting transition going from a peer to a supervisor specifically, but I was so excited to provide that link between the bedside or clinical care and leadership. And in our environment at the time, we did not have clinical nurse managers. We had nurse managers who had very limited inpatient nursing experience themselves. And I felt like I could be a really good bridge at helping them understand what was truly needed to deliver excellent patient care. And like you mentioned, I learned that it was not as easy as you think it is at the bedside. And there's so much more to go into it than just leading by example. And the healthy work environment framework specifically came front of mind. I read it in a publication. A nurse that I was working with happened to mention it one day. And I was like, whoa, I just read something about this. And I don't know if it was AACN or one of the other publications. And we sat down and looked at the time, the prominent figure that helped outline what the healthy work environment framework was. And we're like, this is a really good scale per se of how do we know what we should focus and work on. And while we know it's not going to be equally weighted every day or every month, but in general, we know that we need to make sure the cup is filled in each one of the standards. And for myself specifically, appropriate staffing was so important because, of course, at the time, we were having staffing challenges. And that was made more acute by the fact that we were actually moving into a newly constructed tower and growing from a 16-bed unit to a 32-bed unit. And we had recently brought on a large cohort of new graduate nurses who we welcome and have always welcome in the cardiothoracic ICU. But the volume of new hires was certainly higher than what we had experienced before. And so not only was it about the numbers, it was really about how do we adequately prepare these nurses to transition into practice in this environment and then keep them. And we knew that we were going to experience a lot of, I don't want to say turbulence in the sense of nursing turnover, but just a lot of change. The environment, the technology was new. And while it was a great experience, we knew that the focus needed to be on the newly hired nurses in regards to their onboarding. And we utilized the framework overall to ensure that all of the team members were being recognized. We were effectively communicating about the changes, implementing strong communication or tools that supported strong communication, like a stoplight report, for example, engaging nurses in the work that we do and decisions that we make to ensure that they had buy-in, and that, as leaders, we're leading and we're providing the resources that you need to do the job, but we really want to make sure that while you understand what it's like to take care of patients in the environment, we need to just, in some ways, get out of your way and provide you with the support that you need to do so. And really, that's what initiated my journey into leadership, along with that support of the framework.
Kelly, that just sounds amazing. And like such a great thing for the staff, and it sounds like it's a really great unit to work in. And
it is. It really is. And what I love now about my journey in leadership is I went from being a nurse manager to a director, where now I oversee multiple departments, and the use of that framework has translated very easily across. Now the work's not easy, but it really is relatable. And I think there's so much evidence to help support that we get a lot of buy-in from the team members. Each of our departments has a healthy work environment committee that is structured around the framework. And so transitioning or translating, I should say, the work from unit to unit has also been incredible to see.
That's great. And I do want to share with our listeners that your colleague and partner, Heather Pena, did present the overall outcomes of your department's healthy work environment journey as part of AACN's critical care webinar series in April of this year. And it was an excellent presentation, and I would really encourage our audience to listen to it. And so I think this is a good transition. So from those healthy work environment results, you chose to really focus on the appropriate staffing standards. And so before we dig into those specific strategies that you implemented, can you tell us a little bit more about your unit in regards to maybe experience level, other issues that were uncovered during this deep dive, and whatever else you want to share?
Yeah, of course. Definitely echo your recommendation for Heather's webinar. She's amazing. She spent a lot of time actually focused on the onboarding and orientation of our newly hired nurses, whether they be new to practice or experienced. So definitely recommend that. She'll give you some good tips. Now, when I focused on appropriate staffing, I really had to think about who are we as a department, logistically, operationally, and tie that in with the needs, this kind of softer skills, or the art as we call it. And the department itself is a 32-bed cardiothoracic ICU. We take care of anything that falls into that bucket. So obviously cardiac surgery, thoracic surgery, heart transplant, lung transplant, aortic population, mechanical circulatory support. It's a very busy department. We see probably about 3,500 unique patients a year. We're one of the largest heart transplant programs in the country, one of the largest lung transplant VAD centers in the country. And so we're doing a lot. And while it is an incredibly great unit, the clinical needs of our patients, just like many of our listeners here, are so complex. And we're trying to balance the need for really strong onboarding and clinical care, and in regards to knowledge base, training, things of that nature, but then also just simply the operational needs of the unit, and that we need people on the schedule who can take care of patients independently. And so as a leader, I kind of found myself balancing both worlds, and it's amazing. It's really fun to do. And I say that not in the sense of fun, like a party, but it's really fun to critically think through these problems. And Heather has been certainly a person that has helped navigate this as well. But in addition to her, we are lucky to have 6 clinical or assistant nurse managers. And those assistant nurse managers help us with all of the things. And so we translated from a model of 3 nurse managers. So when I was originally tapped on the shoulder, to a model of 1 nurse manager and 6 assistant nurse managers. And so that was an organizational adjustment or change that we made that was incredible for nursing care. And each one of these assistant nurse managers, while they do have 50% of their time in the bedside, so in a productive mode, that actually helps strengthen the tie between leadership and bedside care. And so us as a team, we're able to not only ensure that we're delivering excellent care, we're all over the unit. We're here on night shift, on weekends, on day shift, and we're able to ensure that the healthy work environment, or the tenets of our healthy work environment, are maintained. We are able to do in real-time coaching or provide feedback. And I think that the broadened leadership team was one of the best things that we could do to foster that healthy work environment. And in addition to just those kind of the size and the population of our team, we'll say that the tenure of the department is largely less than 0 to 1 years. We just broke out of that as a majority. And today, between 1 and 3 years, we're about 45 or 46% between 1 and 3 years experience. We still have about 25% 0 to 1 year. And I say that we just kind of broke out of the majority of 0 to 1 year. And that really means that the majority of our staff have 1 to 2 years of experience. And our turnover, or our turbulence rate, has significantly reduced since the pandemic. We generally will stabilize out somewhere around 20 to 25%, which is high per the statistics that are published. But what I would note with that is we count our turbulence as anyone leaving the organization or those churning within. So transferring from the CTICU to the cath lab, for example. And many of the benchmark statistics really only focus on that turnover, which is nurses leaving the organization. And so I think that's important to point out, that oftentimes we forget that there's a lot more downtime or non-productive time related to that internal transfer than we give recognition to. Whereas our turnover rate is much lower than that. It's about 17%. So people leaving the organization, it's quite low given the tenure of the staff. And we're proud of that. We want people to stay with us. But what we're most focused on is while they're with us, they're engaged, participating in shared governance committees, champion roles, We really want to help build them, their skills, their knowledge, but then also have a lot of productivity with them in teaching and building the knowledge base of others.
Building on that, especially the knowledge and skills, as you know, and we all know, it doesn't matter if you're in a CVICU or a progressive care unit or med surg unit, matching appropriate staffing to competency is key. And it's one of the things that we're passionate about at AACN is the whole competency framework. But like most units, you were given this edict that you needed to keep orientation within 12 weeks, right?
Yeah.
And we've all gone through that. So how did you tackle that? And how did you allow for appropriate staffing and competency within that 12-week time frame? And I know Heather was a key to that success. So I'd love to hear how you did that, because we all are challenged by that.
We are very focused on not just trending our length of orientation, our turnover rate, we balance that with our quality. And I think it's important that departmental leaders make sure that while we're looking at, let's call it our financials, right? So our budgeted 12 weeks of orientation for a new graduate nurse against what is the quality and the outcomes of our patients. And we need to be able to look at that simultaneously. And so we brought this all together. And while we were working to be more financially conscious regarding labor with orientation, we decided to look at things that we were, one, pertinent to our patient population. So for example, CLABSIs. It was something that we had an opportunity for, but we were concerned that if we're going to reduce the length of our orientation, then our CLABSIs would go up even further. And so we wanted to make sure that we have this balance and ability to visualize any untoward effects of reducing our orientation, because to your point, we didn't have a choice. And there are some things that we just were prescribed to do, and we have to carry that out. But how can we do it safely and effectively? And so our team came together, and I will point out, I didn't just take it and I was like, okay, you said so. There was a lot of conversation around this. And at the point, I've been a nurse manager for probably 3 years or something like that. And I'm arguing with senior leaders. So I probably shouldn't have done that. But the point was, how do we make sure that this is the right thing to do? And we were able to pull together the resources that we need in regards to trending data. And that's where Heather really got strong. Heather is very strong when it comes to quality improvement, process improvement, data tracking, analyzing data. And so she was a big proponent to our ability to balance the operations with that quality. And so that's really where she stood out in regards to our entire leadership team in this unit. And prior to the change to going to a 12-week orientation, we were at 16 weeks. So we were essentially cutting a month of orientation for a new graduate nurse. At the time, we predominantly hired new graduate nurses, about 85%. So we really focused on that group. And what we strove to do is, okay, how do we make sure that we maximize the amount of time that the new nurses have at the bedside? So most of our nurses, we're a 12-hour shift model. I will note that we're not a union environment. So I know there's nuances there. So I'll just point that out. We wanted to maximize the amount of time they had at the bedside, but we also knew that there was a need for just didactic learning, pulling the group together, having discussion, working through critical thinking. And so we mapped ourselves out over this 12-week period to have every week the new graduates or the new nurses would work their 3 12-hour shifts and have a 4-hour class. So they wouldn't go over an overtime. We're able to stick within a 1.0 FTE for each individual. In addition to that, one thing that I honestly pushed back at first, but ended up being incredibly helpful, is the first 2 weeks of orientation on our floor, they worked 5 8-hour shifts. And while that did create a little bit of disjoint with preceptor pairing, it was complex. It was hard to schedule. What it allowed the newly hired nurses to do is just really get into unit routines. One, like where to park, how to get in here on time, where to swipe in, listen to our huddle in the morning, our safety huddle, getting report, giving report, just doing your assessments, learning where supplies are, and just getting comfortable in the environment. Because what we recognized was that we would bring a new nurse onto our floor and their schedule might match their preceptors, which is, Monday, Thursday, Sunday. And so they never got into that routine fast enough to then transition quickly into building the knowledge and skills that were needed at the bedside. So those first 2 weeks were 5 8 hours, and then we transitioned into 3 12-hour shifts and a 4-hour class. Another pearl that I like to share is the way that we pair our nurses, our preceptors, with our newly hired nurses, our orientees. We utilize learning style assessments to do that. So each of our preceptors, when they become a preceptor, they take a learning style assessment. So we learn whether they're a visual learner, auditory, or kinesthetic. We do the same thing for all of our new hires. And what we strive to do is match the preceptor and the orientee based on that learning style, because we know that preceptors will generally teach the way that they're most comfortable learning. When we did that, we saw about a 4 to 5% reduction in our request to change preceptors. And so it wasn't a huge reduction, but what we did see was a huge boost of satisfaction in the relationships between our orientees and our preceptors. We also implemented bi-weekly check-ins with the leadership team, the orientee, and the preceptor. And so it would generally be one member of the leadership team who was consistent. In this case, it was Heather, the preceptor, and the orientee. We were very big and open about transparency. I don't want the preceptor to come to me and give me feedback about the orientee that we're not willing to share in a room. It's very important as adult learners to be able to have a conversation, ask questions, and give feedback and get feedback in a safe environment. So that was really a two-way street. And by pairing, or really bundling, all of these things together, we were able to very efficiently move from a 16-week orientation to a 12-week orientation. And in the meantime, actually reduced our rate of hospital-acquired infections, pressure injuries, and also improve our healthy work environment scores. So by looking at both of them simultaneously, we're able to show our staff that this was a positive change, and it is something that is sustainable. And we've done so ever since.
Kelly, I think that's great, is matching the learning styles of the preceptors. And I think it's great for consistency as well. I do have one question just from experience and then things that we've heard through various channels at AACN. When you're orienting, you have that preceptor and orientee duo, right? If staffing is tight or acuity is high, I think listeners would be interested in how you manage the assignment so that, the preceptor pair is not being looked at as two separate individuals.
Absolutely.
And splitting up versus looking at one assignment, one person while that other person is learning. And I think we hear this nationally as a challenge. So I'm curious if that came up and how you addressed it.
It's unfortunate that is such a prominent issue. At the end of the day, the nurses on orientation are not competent. They have not completed their onboarding, their orientation. They have not had their skills check off, most likely. And we practice the married state. And what that means is that the preceptor and the orientee are together. They are one. And I will say that we may have slid by this somehow, but it did not come up. And I'll say it didn't come up because it really wasn't an option for us. Can I say that we, never had the conversation about, this is kind of a heavier assignment. There are two people. I can't say that never came up, and that might actually be appropriate if you're at the end of your orientation period, or it's an experience that the orientee needs to have. But we did have periods of time where our staffing was not good, where we were working a lot of overtime, where we did have incentive dollars to ask people to come in and work extra above their FTE. And so our staffing numbers were not always good. But I will say that we did not separate preceptors and orientees. It's just, in my opinion, and what I've seen, is not appropriate. And in turn, as the leader, it's my responsibility to ensure that we have enough people and they are appropriately trained to care for patients. I always ask myself, whether it be in regards to staffing, whether it be in regards to hiring decisions, HR decisions, would I want this nurse taking care of my family member? And that is always how I am centered and how I know that I'm on the right path in my decision making. And that's what I teach others as well. We have to sometimes make hard decisions as leaders, and sometimes it's, do we not fill a bed because we don't have a nurse? We don't have an appropriately trained nurse. Now, those are not easy conversations to have. The other question, do we bring in agency nurses? Not a conversation that, as a leader, I want to have, not because the agency nurses aren't amazing. It's because they're expensive. And we have to balance that quality and that expense. And one of the interests that I have in leader development, and actually is really relevant in appropriate staffing, is building that financial muscle to be able to talk the talk of our finance partners and help them understand the impact of a potentially unsafe staffing situation that impacts quality, turnover, you name it. But then also the cost of bringing an agency, the cost of using overtime. Chronic overtime leads to burnout, leads to turnover. And so it's just really a balance that there might not be the perfect answer or the right answer, but if we can always center ourselves back to the patient and our staff, the safety of our staff, then we can generally find the right direction. But I'm pretty vocal in my displeasure of splitting preceptors and orientees. One last thing that I actually think is sometimes appropriate is that we have in our mind often a prescription of, we train nurses for 12 weeks, for example. For an experienced nurse, it might be 6 weeks or 8 weeks. It really depends on the experience, but just speaking to a new graduate, 12 weeks. Well, if they're ready in 11, it's okay. They can transfer off orientation in 11 weeks and have their preceptor be their buddy nearby and make sure that they're checked in on more frequently by the charge nurse. It's a team effort. But just because we have a prescription of a length of orientation in mind doesn't mean it can't be shorter, and it doesn't mean it can't be longer if that's necessary.
From what you've described, this is a unit and environment that I would want to work in. And so I can only imagine that your staff engagement has improved. Describe how you measure staff engagement and your wins in this work that you've completed.
Sure. First I'll say that staff engagement begins with the leader, full stop. If I, as a leader, am not engaged myself, I cannot expect my staff to feel as though it's important and value that. And so I think that it really started not just with me, but my entire leadership team of myself and the assistant nurse managers to not only just be present and, of course, fix problems as they arise and things like that. I chose to involve myself in unit-based research, in quality improvement, clinical practice, healthy work environment, really focusing on quality improvement. That really ended up being what I spent the most time on. And it ended up kind of relating into appropriate staffing the most as well. But each one of the assistant nurse managers had a specific interest. So whether that be HAI reduction, whether that be cardiac surgery specific type of knowledge or training. So resuscitation, post-sternotomy, for example. There are little things and broader subject matters that each one of us was really interested in. And we bought into and dedicated ourselves to being engaged so that way we can reflect the importance of that. So that's why you see oftentimes this unit specifically has a huge presence at NTI, for example. They have a huge presence in publications, posters, local conferences, you name it. And it's because it really started many years ago, in that this is what we expect, and we're proud of that. Now, to measure nurse engagement, we did a few different things. One is that we wanted to understand truly just how many people are involved in things, and not just attending meetings, but truly how involved are you in impacting the decisions, or creating change on the department that was necessary, whether that be participating, for example, in a scheduling committee and helping draft the new scheduling guidelines or the holiday scheduling guidelines. And so we were able to do that through a few different ways, but each one of the leaders was kind of responsible for facilitating the committees that we have on the department. We had and still have clinical committees and non-clinical committees. And so we have a good idea of the actual work that's conducted within each of these groups. We manage the individual performance of each person that's engaged, and we do a really good job at what we call coaching conversations, where we document, the contributions of each person. We of course utilize NDNQI. But what I'll say, and I'm not just saying this because I'm on an AACN podcast, but the Healthy Work Environment Assessment tool was and is by far the best tool that we have to measure the engagement of our team. And the reason why I say that is, one, we know it's evidence-based. Two, it's based off of and it complements the framework that we know that we're using. It speaks the same language as we do in regards to that relationship with our staff. And logistically, what I love about it is that we're not having to wait for the organization to decide when to send or bring NDNQI or to send another organizational culture survey. And not that those are not important, but as a unit leader, I need to have some control and ownership over the measurement. And so measuring just once a year or every other year in a department that has a 25% turbulence it's not enough. And so we've been measuring using the Healthy Work Environment Assessment tool every 6 months. And that allows us to keep our finger on the pulse of the culture of our department, specifically engagement. I truly believe that nurse engagement is the key driver to retention. And when we look at retention, it's not just who's leaving, it's really looking at how long are they staying. We don't expect nurses to stay with us for 15 years anymore. We're realists. And so we have come to the understanding that if we can keep someone, the literature says if you can keep them for 5, they're going to likely stay long-term. Right now we're looking for 3. And the reason why I say 3 is because we have incremental improvement. That's kind of our thought process of, we were at 0 to 1 for the predominant kind of grouping. Now we're 1 to 3 for our predominant grouping. So let's keep pushing that forward. And like I said at the start, if we can engage them while they're here as early as possible, then that's likely going to lead to ownership of the department, relationships. So that's social capital that's so important, but also just, your professional growth and development. People don't want to jump around. They're jumping around to find something else. And if you want to be a CTICU nurse, this is where it's at. We have everything, and it's a great team that's well resourced. So culture is the one thing that we can really, really control, because everything else is as strong as it can be. And so if culture is something that we can improve incrementally, which again is really driven by engagement, then we'll see that retention. And so some of the work that you might see of ours out there speaks to, I might have had nurses who stayed for 365 days on average, or that's our median. Well, if I can see that incrementally improve year over year, every 6 months, I'm happy with that. I'm not trying to go from 1 year or 2 year length of tenure to 10 years, because we won't get there. I will also say that sometimes departments and leaders are afraid or just don't have the mindset of engaging nurses as early as possible. And I'm kind of the opposite. I'm all about, they need to learn the clinical practice and the knowledge at the bedside, but I also want to hear their ideas. There are new nurses. They're very innovative. They've seen things done different ways in other places, whether it be through school or if they've had a job previously. And, they just see the world differently, and that's good. And if we don't lean into that, then we're going to lose them. And so I think that, having strict guidelines on not allowing people to join a committee for a year or, whatever that might be, I think that's probably not the approach we should be taking anymore.
Thank you so much for that. I think that are all really important concepts, and a couple of things that continue to come up in the conversation in regards to, retention and then turbulence within the unit, changing, leaving the organization or changing departments within the hospital brings me to a point. So we understand that one of the steps that you took as a leader was really to quantify and project out your expected turnover so that you could hire ahead of your vacancy so that you would avoid staffing shortages. And this strategy has been really successful, and Duke has actually adopted it as a system-wide strategy.
That's right. Yes. This is where graduate school changed my life. And the reason why I say that is when I became a nurse manager, I remember sitting down and I was like, how do we even know what to do? People don't like when I say this. I'm trained as a nurse. I didn't go to school for finance. I have a bachelor's at this point. But I need to learn this. This is now my job. This is my responsibility. And this is something that I need to take ownership of. And so I self-taught with a mentor that I still have. She's actually my supervisor, but she and I got together and really looked at how it is that we can understand the number of FTEs that we need. So how many FTEs do we need just to make a schedule? And then how many FTEs do we need to ensure that we can kind of allow for nurse engagement? So what we would refer to as indirect time or non-productive time. So for education, meetings, orientation, things like that. And then how many do we actually have? And what was amazing to me is that I recognized being a young leader is that we don't have any tools that tell us these things. We built out our Excel spreadsheets where we would have the list of our staff, their corresponding FTE, what competencies they had, their tenure, things like that. And then we would go back to our budget and we'd say, okay, we're budgeted for this hour per patient day, which I had to learn all about that. How many FTEs are we budgeted for? What is our expected census? And we had to put it all together. And over time, we recognized, all right, well, now we know what we have. Now we know what we need. But how do I know how many nurses to hire right now? Because I'm so heavily, let's say, reliant on new graduate nurses who really are predominantly available twice a year, right? You have your May grads and your December grads. Now we're lucky to have generally a third cohort in August. But at the time, it was really twice a year. And knowing the time to fill a position for a new graduate nurse, the time to start, and then the time to train, it's somewhere between 6 and 8 months. And it's pretty competitive to hire new graduates nowadays that particularly have some sort of exposure to critical care during nursing school. And so we built out some calculations and algorithms that we, like you said, still use today to determine how many nurses we should hire and when, to ensure that we don't have periods of short staffing throughout the year. Now, the organization, so Duke is well resourced, right? Like, Duke has financial challenges like everyone else. But what I mean by well resourced is that we have folks that help us with data. We have technology that can help us, build dashboards and reports and things of that. But we didn't have anything specific to nursing. And we still honestly don't built internally. We do have some really great tools and things like that. But this eventually led to my graduate school work of evaluating on a larger scale a standardized way to calculate RN hiring needs. And so we did this study across 2 hospitals of our health system. And we saw really great outcomes. This was during my DNP, actually, that we did that. And it blossomed into an innovation where we've actually created a software. It's called HealthForce, that automatically calculates this work for the leaders. And so this software, it really fills this missing piece of, we have the position control that tells us who we have our budget, which tells us what we need, but it never talks to each other. So HealthForce brings it all together to help us understand how many we have, how many we need to function, and how many we need to hire to continue the workforce stability. And so it brings together really all of the tools that a nurse manager needs. Anything that you think that you'd have on a spreadsheet is within this software. And so it's really carried on to now it's deployed across Duke Health and is used really consistently. And it's able to show at a local level, at a service line level, and also at an organizational level, what are our staffing projections now through the next 9 months, how many travel nurses we have, how many we might need, how many nurses do we have coming and going at any given time. And it really is just the tool that's at our fingertips now to be able to automate a lot of that work and reduce the administrative burden for the leader, thus allowing us to spend more time with our team.
Well, Kelly, I could go on forever listening to you because you have done some absolutely amazing work. And we are lucky within the nursing profession to have you in a leadership position. So I'm grateful that somebody tapped your shoulder and you answered that tap. As we draw to a conclusion, I know that many of our listeners are direct care nurses, and they're sitting there thinking, well, I don't have a manager or a director like Kelly. So what message would you leave them with?
My message to the direct care nurses is to get involved. There are going to be leaders, directors, managers who are not bought in to engagement or healthy work environment, but you don't need your manager's permission to lead a healthy work environment. And nurse engagement is a big factor in that. And so getting involved allows you to influence the decisions. It allows you to influence the culture of the department. And it allows you to build relationships with one another between your team members to identify where the strengths and weaknesses are so that you can balance each other out. I do believe in leadership development. I think that's really important. And as a bedside care nurse, involving yourself in any opportunity to develop as a leader, whether that be that you want to strengthen your communication skills, you want to strengthen your ability to give feedback to others. Those are things that are going to prepare you to get tapped on the shoulder. And just to put a plug out there for leadership, it is very hard. Just like bedside nursing is hard, it's just a different hard, but there's so much opportunity and ability to influence not only the nursing team, but truly patient care. And if you're on the fence about taking the leadership path, just go for it because there's so much amazing work to be done. And we need people with energy and folks that have been close to the bedside recently to make that change happen.
Well, again, we just want to thank you for spending this time with us. And thank you for all the incredible work you've done and will continue to do. And I plan to keep an eye on you and the work that you do because it has been amazing. As we conclude, I just want to remind all of our listeners that we want your feedback. If you have ideas for guests or topic areas, please email us at podcasts@aacn.org. And until next time, we will talk to you later.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's award-winning quarterly journal, AACN's Advanced Critical Care, with information available at www.aacn.org/advancedcc.